Bye.
Hello, everybody. Welcome to Knock Knock Eye with me, your host, Dr. Glockenflecken, your one-stop shop for all things eyeball related. We got some good eyeball stuff today. I've got a couple pet peeves, some eye bones to pick. There are no bones in the eye, but much to ortho's dismay. But I have some eye bones to pick with Hollywood, and also I have a mystery case. You guys seem to like the mystery cases, so I've got one for you. Let's see what else is recently happened. Here's something. Once again, I come across people who are surprised to find out that I still practice medicine. It's like becoming just accepted. Like the more you see someone on social media, like the less likely they are to be actually seeing patients. And it doesn't bother me. I'm surprised. It's like the assumption is, well, how can you have time to do both? And I just, you know, in my mind, I'm like, why would I, why would I want to quit this practicing medicine? It gives authenticity to my content. I honestly can't imagine like doing one without the other. And I do caution young people who are developing a social media following not to quit your day job. And I'll give you a reason why. It's for as much as we complain about being a doctor, practicing medicine, and all the failings of our healthcare system, it is a remarkably stable profession. Like if you find yourself as a physician in a situation that's not good for you, maybe you don't like your employer, you're in a failing practice or a failing hospital, or your hospital gets bought out by PE and all of a sudden the culture tanks, which is what's almost guaranteed to happen. You can find somewhere else to get a job. Like the job, I feel like there's always a place that's looking for your services. It might not be a place you care to move to, but there's a place, right? There's a job market. There's always going to be a job market no matter what specialty you're in. And it's easy to overlook that. And so when you're talking about like content creation, which man, yeah, absolutely, you can make more than you make as a physician doing content, doing ads, speaking, all the things. It can add up and you can make a good living. But it is so unstable. Um, just a couple of years ago, one of the big sources of revenue for content creators is ad revenue that comes in just through people watching because of views. So like every platform has a system in place to give creators some money based on how many people just watch their stuff. So TikTok has the creator fund, which really honestly pays you pennies. It's very minimal. YouTube historically has been the best, especially with long form content. But a couple of years ago, they reclassified what a short is, a YouTube short, from 60 seconds to 90 seconds. So like for me, for instance, like I was making really good money on YouTube, posting my 120-second videos, 2 minutes. Most of my videos were either, a minute and a half, 2 minutes, maybe 2.5 minutes, and they were classified as long form content. So I was making long form money on sometimes 1 million views on these. And it was good. I was just making several $1,000s per video. It was great. And then a couple of years ago, YouTube decided to reclassify. They were probably realizing, wait a second, people like this comedian ophthalmologist guy, they're only making they can make these videos so quickly, and it's all long form. And he's getting paid a bunch of money. We gotta fix this because he's able to do this like 3 times a week, making these videos. We're losing way too much money on this. So they reclassified as more short form content creators, like primarily like myself, began posting on YouTube and making money and monetizing. They realized they had to do something. It's just the TikTokification of content. And so YouTube decided, okay, a short, which was paying about what TikTok was paying, so not very much money. Uh, a short is no longer just anything under 60 seconds. It was anything under 3 minutes. So all of my content, all of a sudden, bam, no longer long form. It's now a short. It's being, making money from an alternate source, like a different pile of money that's a fraction of what long form was. So all of a sudden, it was like overnight, my YouTube income like tanked. Now, that's fine. It was kind of annoying, right? Because it's great to make more money off of something you create. But it wasn't the end of the world because I'm not primarily doing this to make a living. I have my job as a doctor, which pays great. So there's a lesson in that. The volatility of content creation is something that like people, you can be tricked into thinking like I can work from home, I can make my content, I can post it, but you don't have any control over your audience or the social media algorithms. One change, bam, you're done. All right. So sure is nice to have a steady career to fall back on. And so that's a big reason why I still practice 4 days a week, full time for an ophthalmologist, by the way. And I'm not going to give it up. It's partly because of that, because it's a wonderful, stable career in a time in 2025 where, man, a lot of people are struggling to find work. It's certainly nice to have that. And the volatility of content creation, you're really, you can think you're your own boss as a content creator, but really you're not. I mean, you are with respect to when you work, but in the flow of money, like you don't have control over that. One change and you're done. Your income is cut in half or even less. And so I encourage people like don't think of content creation as like a career. It can be a career and people do it, but it can go away very easily. Something that being a doctor will not go away very easily. All right, it's going to take a lot more. Even AI, like all the doomsday, being there's going to be robots, AI that can do a doctor's job better than a doctor. I don't buy any of that. I don't buy it at all. Because when it comes down to it, human beings, patients, they don't fundamentally don't want an AI doctor. They want a human being. This is very sensitive stuff. Your body, your health, your life. You want a person. And I don't think that's going to change. If anything, people will just be craving more of a human presence in their healthcare when AI does start to encroach around the edges, which is not something we can really avoid. And in some ways we should embrace, but I don't buy that. So keep being I guess the point is keep being a doctor. Like don't quit your day job for a fad. Don't like not that content creation's a fad. It's a great hobby. I guess that's my point. It's a fantastic hobby. It's a great way to make a little extra money. But man, having a nice stable career to fall back on, it's hard to put a price on that. All right, let's two other things before we take a break. All right, so a couple pet peeves. This is just you know two things I see in like Hollywood, in movies and TV shows that and also one thing in just like daily life that I wish would go away. I wish we could get some education about this. All right, and this is, I don't have any good segue into this. It's just something that's been on my mind. Um, in When a character has an eye pop out of their head, can we have it stop dangling on the cheek? It doesn't happen. The optic nerve is not long enough. If it's long enough to dangle on the cheek, there's nothing holding that eye still in place, and it's just going to fall out completely. All right, just no more, none of the dangling on the cheek. There's not enough. There's a little bit of redundancy to the optic nerve. It's important for you to have a little bit of redundancy, but it's not nearly enough for it to just be kind of waving around on your cheek. You could just like swing it around your face. Come on, like what are we doing here? Can we please just get an ophthalmologist to consult? And I hope I don't see this in the pit. Season 2 is coming up. I feel like they have more sense on that show than the other shows and movies. I'm available. I've never once been approached to give some accurate ophthalmology education, data points, whatever you need to create accuracy in your medical show or movie. I'm here. I'm here, folks. All right. I got one more pet peeve. Let's take a quick break. We'll come back. Hey, Kristen.
Yeah.
How come people only talk about being cozy and warm and wrapped up during the holidays?
I don't know. I like to be cozy all year long, every single month.
Exactly. When the holidays wind down, that's what I crave the most. I still want to feel that way.
Right. And I need a lot of rest after the holidays. So it's nice to be able to wrap yourself up in
And that's exactly what Cozy Earth delivers. Luxury comfort that makes home the best part of your life. And now you can get a 100-night sleep trial with Cozy Earth and a 10-year warranty, because once you feel this level of comfort, you'll want it to last a whole decade.
That's right.
Start the new year off right and give your home the luxury it deserves and make home the best part of your life. Go to CozyEarth.com and use my code KNOCK for up to 20% off. And if you get a post-purchase survey, be sure to mention you heard about Cozy Earth right here. Give the gift of comfort that lasts beyond the holidays and carries into a cozy new year. All right, so no more eye dangling on the face. It's call an ophthalmologist when that happens. All right, when the eye pops out of the head. All right, the other thing is the terminology "lazy eye." We gotta talk. I just want all of us, at least all the knock knock eye listeners. I want us all to be on the same page here. All right, ask yourself right now. I'd be curious to know, what do you think when you hear lazy eye? You say, I have a lazy eye. What do you think? I would guess that most people define a lazy eye as an eye that's pointed in the wrong direction. Either it's pointed in toward the nose, esotropia, or it's pointed out, exotropia. Basically, you got one eye not pointing in the right direction. Folks, that is not a lazy eye. Now, that is strabismus. Strabismus, and it can result in a lazy eye. All right. But that is not a lazy eye. Just because someone has an eye pointing in a weird direction doesn't mean it's a, quote, lazy eye. A lazy eye is when you have amblyopia. A lazy eye means that eye has not learned to see. And it might be because one eye is pointed out. You have strabismus that can lead to a lazy eye, but they're not synonymous. Lazy eye and an eye pointing out. They're different things. Right? Lazy eye is when an eye is weaker in vision and visual acuity because something happened, whether it's strabismus or a big difference in the glasses prescription. Like one eye is like a +3, the other one's a -3. Like when you're growing up, if that's the case, you're going to turn off that eye and you might end up with a lazy eye. An eye that just doesn't see as well as it normally would have because the brain didn't develop normal vision. It became lazy. That is a lazy eye. All right. Not just strabismus. Let's get our terminology right. All right. This is a very nitpicky things. I know I'm probably being quite pedantic here, but just bear with me. I am an ophthalmologist. I have to care about these things. If we don't have anybody to care about this, then the history books change forever. And all of a sudden strabismus becomes lazy eye. And I can't accept that. I cannot accept that. So please help me out here. All right. That's the end of my pet peeve list. I'll keep up with the pet peeves. What pet peeves do you guys have for medical? I know you got a lot of medical folks listen to me. And you're especially, what's the thing? The thing that makes when you bring it up to non-medical people, they roll their eyes. They're like, why does it matter? It's a TV show. It's fake. All right, just accept it. Suspend your disbelief. What are the things you can't let go of? I would love to know. I'll share them on this podcast. All right. All right, let's get into it. Should we get into our case? Let's do it. All right. So this is a mystery case. All right. Chief complaint. We'll start with that. Acute onset Diplopia, double vision. All right. Now remember, double vision, right off the bat, two different types. There's monocular double vision, so dry eye, things that are not that severe, not an emergency, and there's binocular diplopia. That's where you cover an eye, either eye, and the double vision goes away. You cover the other eye, the double vision goes away. That is binocular diplopia. You have to have both eyes seeing in order to experience the diplopia. That's the diplopia we get concerned about. All right, so acute onset diplopia in this patient. This is a 47-year-old man, history of Crohn's disease, who presented to the emergency room with a sudden onset double vision. A month prior to this presentation, he had diarrhea for about 3 weeks, which he presumed to be a flare of his Crohn's disease, which is a reasonable assumption, right? Diarrhea is a frequent occurrence for people with Crohn's disease, especially when you're having an active flare. He was treated with oral prednisone, which he took for about 3 days. On the 4th day, he woke up with binocular and oblique. So it was binocular, so obviously both eyes. We just talked about that. And the double vision was oblique, so diagonal to each other, the two images. And that's challenging. That can be that usually, honestly, often means that there's like multiple. It could mean that there's multiple muscles involved. And he was unable to move his eyes in any direction. A little unusual. So thinking the double vision was related to the prednisone, the patient stopped taking the prednisone. In the ER, he was evaluated by a neurologist who noted complete bilateral ophthalmoplegia. So neither eye was moving at all. Obviously, a CT scan was done, a brain MRI of the brain with contrast, and the MRA, so an MRI angiography of the head with contrast, were done. And can you guess what those showed? Nothing. Unremarkable. Interesting. So when you think of, my thought is whenever you have multiple eye muscles not working, then you're thinking of, okay, maybe multiple cranial nerves, right? Because you have cranial nerve 3, which is responsible for the superior rectus, inferior rectus, medial rectus, and the inferior oblique. And you have some multiple muscles. You also have the 4th cranial nerve, which is responsible for the superior oblique. And then the 6th cranial nerve, which is responsible for the lateral rectus, right? So 3 different cranial nerves in order to get all the muscles around the eye functioning. And where is the point in the brain where all of those muscles kind of come in close proximity to each other? The cavernous sinus. So that's one place in the middle of the brain that we're looking for any kind of pathology, a thrombus, a dissection, something bleeding, a tumor. And so that's why, obviously, when you see all these muscles not working around the eye, you're going to get the MRI to look and see what's going on in there. Unremarkable. Interesting, right? So then you're thinking of, here's my thought process and hearing the story is, okay, well, then what else? What else can cause multiple muscles? In this case, it seems, I haven't seen the patient yet, all the muscles not functioning. I'm thinking about this as I'm driving into the emergency room, right? What else could it be with normal neuroimaging? All right, so you're thinking about, okay, maybe it's a dysfunction of the muscle itself, not so much the innervation, but the muscle fibers aren't working. And what's one of the more common things that could be? Myasthenia gravis. All right. So, and the neurologist thought about this. So, an acetylcholine receptor antibody test was done due to concern for that. So, that's an antibody that's commonly associated with myasthenia gravis. That was negative. And then you think of other random things. At this, I'm not sure the connection here, but the patient was started on doxycycline for possible Lyme disease. Didn't think that was very likely. And then the patient was referred emergently over to the ophthalmology clinic. And so a patient comes into clinic. At that time of the eye appointment, in addition to persistent double vision and ophthalmoplegia. He also had reduced color vision and headaches that he thought was eye strain, also eye pain and upward gaze. Pretty, non-specific types of symptoms. So on exam, here we go. We've gotten all the history we need here. Still don't quite know what's going on, but it's not seeming like myasthenia gravis because the antibody was negative. Now, you can have seronegative myasthenia gravis. That's certainly possible. So we haven't totally ruled out myasthenia gravis, but we've ruled out a lot of the things that would show up on an MRI, right? Stroke, tumor, thrombus in a very sensitive spot in the brain. Um, so we're still kind of not quite sure what's going on. All right. So on exam, vision's great, 20/20, both eyes. Eye pressure's normal. The pupil exam shows no RAPD, so normal pupil reactivity. Pupils were equal, round, reactive to light. Perla, we got Perla here. Confrontation visual fields, normal. Get up to the slit lamp, take a look. Everything looks great. There's a little bit of ptosis. So the right eye, the right upper eyelid is a little bit lower than the left, but the normal strength. So you're thinking about could there be some kind of like uh, um, Bell's palsy, which wouldn't explain all the symptoms, but can give you a ptosis. Nothing there. There's nothing called there's a thing called a Kogan lid twitch, which is a flicker of the eyelids whenever you're going from an up gaze down to central gaze. You're moving the eyes up and down. You can get a little irregular twitch that can be seen in thyroid disease because obviously that's on the differential with multiple muscles that aren't working, but not ophthalmoplegia. That you don't see with thyroid. So we look at the back of the eye, still don't have nothing showing up on the exam really. So normal slit lamp exam, normal fundus exam. The optic nerves look great. The periphery, everything, retina looks just fine. And also, occasionally, we'll do some reflex testing in the eye clinic, and reflexes were normal. Normal gait, normal everything. And so this is something, I see this patient in the emergency room or in the comprehensive eye clinic. I don't know what's going on here. The imaging's been done. So who do we usually send to the patients where we really don't have a good idea what's happening? The neuro-ophthalmologist. And so that's where this patient got sent directly to the neuro-ophthalmology clinic because this is concerning. Complete ophthalmoplegia. And so what the neuro-ophthalmology clinic did was they sent a few other antibody tests. All right, so they looked for lots of different things that can affect the cavernous sinus, that can affect the eye muscle movement, a lot of autoimmune conditions. All right. So, in addition to the acetylcholine receptor antibody that was already sent, they repeated that just to make sure that it was actually negative, looking at possible myasthenia. Also, muscle specific kinase antibodies, just basically looking for any sign of muscle dysfunction. Also, a CT of the chest, looking for like a thymoma, which can be seen in myasthenia. A neostigmine test was performed in the clinic. So we do that to really see, we're trying to rule out myasthenia gravis here because that still is at the top of the list. So we talked about potential for seronegative, where you have myasthenia, but you just don't have any antibodies specific for that disease that show up on blood testing. And so a neostigmine test is performed, which shows the patient felt a little bit of improvement. And so, given the positive test, we're still thinking, okay, this could be seronegative ocular myasthenia. That was initially thought to be the diagnosis. The patient, because of this kind of borderline positive neostigmine test, where you give a medication and then the ptosis improves. Some of the motility might improve a little bit, and so that's the thinking at this point. All right. This is ocular myasthenia. Patient was restarted on oral steroid as well as oral pyridostigmine. So these are common medications to treat ocular myasthenia. Encouraged to wear an eye patch that helps with dealing with the double vision. You just block one eye and the double vision goes away, and that can just help people to be able to function, even drive. So repeat that again, I mentioned they repeated the serology. It still was negative. The acetylcholine receptor antibody was still negative. So it's a very strange picture, right? Because you have what looks like clinically, it looks like you're improving things with the classic treatment for myasthenia, but none of the blood tests reflect this. And so what they did in the neuro-ophthalmology clinic was they did a test called GQ1B antibody. And this is obtained to rule out a disease called Miller-Fisher syndrome. And guess what? That test returned positive. So we're going to get to what this is. GQ1B antibody was positive. All right, so this essentially made the diagnosis of Miller-Fisher syndrome, MFS. So Miller-Fisher syndrome is a rare subtype of something that a lot of people know a little bit more about, which is Guillain-Barré syndrome. So Guillain-Barré is you know what? Let's take one more break, and then we're going to dive into what this patient had, this Miller-Fisher syndrome. Hey, Kristen.
Yeah.
I just have to talk more about Demodex blepharitis.
I'm sure you do.
I just love all things eyeballs, but not the mites this time, though.
Okay. I appreciate that. Thank you.
We're talking about collarettes.
Okay, the crusties.
Crusties.
Yeah.
Yeah, it's kind of a cute name for Demodex blepharitis.
I guess.
Finding on
Sure.
exam. The thing is, I want to educate patients that you can't always see these things yourself.
Oh, so, and you can't feel them?
No, because they're so small. So you have to come in to see the eye doctor, either an optometrist or an ophthalmologist. We use a microscope. We can see all the collarettes on there.
Okay.
And because it's hard for people to connect this sign on your exam with all the symptoms.
Because they can't even see it or feel it.
Right. The itchiness, the redness, the irritation that could be due to Demodex blepharitis. It's a great time now to make an appointment with your eye doctor before the end of the year and deductibles reset.
Yes.
You got to
Very important.
To see more pictures of crusties and eyelids with Demodex blepharitis, visit miteslovelids.com. Again, that's miteslovelids.com to learn more. This ad is brought to you by Tarsus Pharmaceuticals. All right, so Miller-Fisher syndrome, which is what our patient with complete ophthalmoplegia, but otherwise a normal eye exam. It's looking like this is what this patient has because of a positive lab test of GQ1B antibody. Okay, so this is a rare subtype of Guillain-Barré, which is an immune-mediated polyneuropathy characterized by acute ascending motor weakness and areflexia. So I mentioned that we had checked reflexes in clinic, and the reflexes were normal. So initially, Miller-Fisher syndrome was not on our high. It was on the differential, but not high on the differential, because usually you have, with Guillain-Barré, with these types of polyneuropathies, you have areflexia or significantly reduced reflexes. With Guillain-Barré, you have reduced reflexes. But these are both very rare diseases. And Miller-Fisher syndrome, as opposed to Guillain-Barré, so I'll kind of compare and contrast the two. So Guillain-Barré, you have ascending limb weakness. It starts in the legs and feet, potentially spreading upwards. And if it affects the lungs, the diaphragm, then you can become intubated and because of this. Miller-Fisher syndrome presents with eye paralysis, ophthalmoplegia, but typically balance problems and absent reflexes. So obviously there's one thing that goes with this for our patient, but the absent reflexes, we didn't see that initially. These diseases, the Miller-Fisher and Guillain-Barré, they share the same autoimmune kind of root, but they differ in the primary symptoms, as I just mentioned. And Miller-Fisher syndrome will often have this anti-GQ1B antibody. That's the way to distinguish between Miller-Fisher syndrome and other diseases. And Miller-Fisher syndrome is usually milder and resolves faster, but it can overlap with GBS. Miller-Fisher can become Guillain-Barré if you have spreading weakness that starts to affect other nerves. But often it's just ophthalmoplegia. And both of these syndromes can be treated with IVIG or plasma exchange. Basically, you just use, I'm not an expert in this, but you use like fancy technology to remove the harmful antibodies that are leading to all this muscle dysfunction, this dysfunction of the nerves that allow these muscles to fire. And so again, very rare. And I can, as far as the clinical course of this patient, so 3 weeks later, the patient did not need to be admitted because, again, this is all just around the eye. So it didn't have anything that suggests there was also like a Guillain-Barré component where you had, obviously, if you have polyneuropathy that's starting to affect the legs, like patients can't walk. Often they have to be admitted, and then you have to watch out for respiratory issues. Um, the patient called 3 weeks later and reported that the diplopia, after being started back on the steroid, was improving. He had stopped taking the pyridostigmine because of side effects, which is fine because this wasn't myasthenia gravis, so it probably wasn't that necessary to treat with that. But he continued to take the 20 milligrams of prednisone daily. He didn't feel like the symptoms were or the prednisone was helping. It might have been because he needed a higher dose, honestly. But this is it will, is a self-limited course. Both of these syndromes, Miller-Fisher and Guillain-Barré. Um, Given the lack of response, subjective response that the patient felt, these didn't help. Ocular myasthenia was felt to be less likely. And despite the lack of ataxia and areflexia, Miller-Fisher syndrome was felt at this point the most likely given the positive GQ1B antibody and the history of diarrhea illness weeks before the onset of ocular symptoms. So that's the key here, because one of the most common infections that will kick off this type of autoimmune condition, Miller-Fisher syndrome and Guillain-Barré, is Campylobacter. There's a whole host of them, though. Haemophilus influenza is another one, cytomegalovirus, mycoplasma, Epstein-Barr virus, group A strep, Coxiella, Pasteurella. I barely know what any of these are. We got to get the infectious disease doctor on these. But Campylobacter is the most common. And so you had this patient who comes in with a history of Crohn's disease, and you're thinking, oh, this is a Crohn's flare. But no, it was actually probably an infectious diarrhea. Now, what was one, like, were they related, right? Was the fact that this patient has Crohn's, might have bleeding in the GI tract that maybe could have allowed an infection to set in. I don't know enough about the GI tract and inflammatory bowel disease to know. But I think initially this was written off as, okay, this is probably just a flare of Crohn's disease. But in hindsight, it was probably this specific infection that kicked off this autoimmune condition leading to Miller-Fisher syndrome. And the patient overall did great. Returned 2 months later, still had a little bit of diplopia, but the ptosis was resolved, had full motility. Remember, initially there was no motility. There was no function of these muscles around the eye. But his movements were back to normal, still had quite a bit of an esotropia. So the alignment wasn't totally normal. But given his progress, there was, thought to be good prognosis, and the patient ended up making a full spontaneous recovery. So this patient didn't need IVIG or any plasmapheresis to remove those harmful antibodies. It resolved on its own. And so prognosis is good with something like this, a good outcome here. But this was an interesting case I have not seen any other patient similar to this. And the take home lesson here for all of you, thank goodness we have neuro-ophthalmologists. I just want to once again shout out my neuro-ophthalmology colleagues, because, like, I would have not ever really thought to send a GQ1B antibody test. I I didn't know, honestly, until like reading about this again now years later, that I forgot that was even a thing, that you can test for this Guillain-Barré variant, Miller-Fisher syndrome. It's very specific with this antibody. So GQ1B, yeah, Miller-Fisher. Who knew? All right, interesting. All right, that's it. That's all I got for that was our mystery case. Something that probably not going to happen. So Guillain-Barré, just to let you know, 1 to 2 cases per 100,000 people. So very rare, not extraordinarily rare, but very uncommon. And Miller-Fisher syndrome is estimated to be anywhere from 1 to 7% of Guillain-Barré cases. So you take that 1 to 2 per 100,000 and you take like 1 to 7% of those. So it just gives you a sense of just how rare this Miller-Fisher syndrome variant is. There's a slight male predominance, but it affects all age groups. They're typically adults more than children. You see this more in adults, but regardless, very common. And I have my wife's voice in my head because she's always wondering, well, why does it happen? What is like on a cellular level? Like what is going on? So you get on a very basic level cross-reactive antibodies that are against this infectious bacteria. Campylobacter will take, just, assuming that's what this was, that attacks the cell membrane gangliosides, things that are kind of attached to the cell membrane, allow it to communicate with other cells, that's present in cranial nerve 3, 4, and 6. And the muscle spindles. So not only affects the cranial nerves, but it affects the muscle cells themselves, the spindles. And so that's why. So these very, very specific antibodies that are developed attack specifically the cranial nerves that innervate the eyes and the eye muscle fibers themselves. So there you go. All right. That's Knock Knock Eye. Thank you all for bearing with me. That's a very complicated case. I tried to make it as simplified as possible, but that was a tough one. And you're going to find a theme with these mystery cases. A lot of them are neuro-ophthalmology related because that's where a lot of the mystery comes in ophthalmology. And part of that's because, like, in ophthalmology, we can see pretty much everything that we're treating. Like, if something happens with the eyeball, like, we can see it. It's there. Like, it's obvious. But when it comes to neuro, the nerves, the cranial nerves, the brain, obviously that's like more inside the body, and it's bordering on dangerous, like internal medicine, area, or neurologists. Thank goodness we have those. But anyway, you're going to see there's a flavor of mystery cases that's going to be heavily in the neuro-ophthalmology realm, which I think they're interesting cases for sure. I'll try to sprinkle in some other areas of the eye that might be affected too, that I can do realistically on a podcast and still make it interesting. All right, but thank you all for listening. Again, I'm your host, Will Flannery, also known as Dr. Glaucom Flecken. Thanks to my executive producers, Aaron Courtney, Rob Goldman, and Shanti Brick. Editor and engineers, Jason Pertizo. Our music is by Omer Benzvi. Knock Knock Eye is a human content production. We'll see you next week, everyone.
Knock, knock. Goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below, let us know what you think.